Hello, I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the Eating the Last Few Christmas Sweets from the Bottom of the Tin episode of the Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
So grab your preferred drink of choice or your trainers and bring your hopes for the new year. Here's what's bubbling up this time as we dive into the Red Whale Aquarium in search of our pearls. Cough, 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 vomits, spotting pertussis. As we sift through the winter urties and coughs, one diagnosis we should consider is pertussis or whooping cough. But when was the last time you made this diagnosis?
Antibiotic prophylaxis for sexually transmitted infections. Yes or no? In 2021, the British Association for Sexual Health and HIV and the UK Health Security Agency published a joint position statement against using antibiotics for prophylaxis against STIs. That's separate to the advice around drugs for prophylaxis of HIV, which are still endorsed. So, what is our role in primary care if a patient approaches us for advice?
And here's what's bubbling under for next time. Wintering, time to restore ourselves. We share an article from our lifestyle medicine course offering a roadmap to well-being that we can use to support ourselves, family members and patients as we embark on 2025. So back to the top of the list and our first pearl and pertussis. Now this one took me 16 minutes and 44 seconds to read, so quite a chunky one to start with. You might need maybe to crack open the tea or the coffee and the fruit toast for this one. So Ali, what did this one mean for you?
Well, Nick, honestly, I was really worried when I saw we were doing this topic because I've got a horrible memory of asking a question about pertussis in a packed lecture theatre at medical school and pronouncing the W in whooping cough, so like whooping cough, and the lecturer pointed it out and everyone laughed at me, and I still sometimes right before I say it get a moment of panic that I'm saying it wrong, so I think I'm just going to go with pertussis, if that's all right.
Well, that's all right, but it's interesting because I was thinking this, so we call it whooping cough, don't we? But then I'm sure when you describe the bit of the cough which is classical for pertussis, I'm sure we don't call that a hoop. I'm sure we call that a whoop, or so I don't know. So I'm with you on that. So I'm really sorry that it's triggered you.
Well, yeah. Is it a hoop or a whoop? Yeah, I don't know.
Because you can make a whooping noise, can't you? You know, whoop whoop kind of thing.
But then logically, it should be whooping cough.
Exactly. So maybe all these years later, you were right. Quite frankly.
Sure.
So shall we try not to trigger you too much and go on and talk about pertussis or whooping cough? So it's a respiratory infection caused by the bacterium Bordetella pertussis. It has cyclical peaks every 3 to 5 years. Now, peaks were seen in 2012 and 2016, but COVID reduced pertussis infections to very low levels. The most recent peak commenced in late 2023. Now, pertussis is important because it remains a preventable cause of infant hospitalisation and death. Vaccination during pregnancy can provide passive immunity to infants before they complete routine immunisations. With each peak, there are a number of infant deaths, mostly in children born to unvaccinated mothers. Unfortunately, neither infection nor immunisation provide lifelong immunity, and therefore cycles of pertussis infection continue. Now, the article on Red Whale Knowledge, which was released as the Pearl, was last reviewed in September 2024, and it's a summary of the latest on pertussis from the BMJ in 2019 and the UK HSA guidance on the management of cases of pertussis in England during the re-emergence of pertussis in 2024. Full references are in the written Pearl, they're on Red Whale Knowledge as well, and they are also in the show notes. So let's take a look at the finer details of pertussis. Ali.
Yeah, so the incubation period is 4 to 21 days. Transmission is via airborne droplets. And thinking about prevalence, the peak incidence in childhood is from around 6 months of age. But remember that 3% of adults presenting to primary care with an acute cough will have pertussis. And presentation...
hang on a minute. Back up the truck. Did you just say that 3% of adults presenting to primary care with an acute cough have pertussis? Do you think we're diagnosing that many?
Yeah, that statistic is wild, isn't it? Yeah, I suspect we are not diagnosing that many.
Yeah, and I guess it's one of those things that if you don't think about it, then you won't make the diagnosis. So before I so rudely interrupted you, you were telling us about presentation, I think.
Yes. Not yes, you were being rude, by the way, because you weren't. But yes, I was telling you about presentation. So yes, presentation would be with an upper respiratory tract infection type picture. So low-grade fever and cough, followed by what are termed the classic signs of pertussis. So these are paroxysms of coughing, followed by an inspiratory whoop and vomiting. Remember, though, that vaccinated individuals may not whoop and they may present with cough, 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 vomit.
Now, rather than either of us doing our best impressions of a whoop or indeed a cough, 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 vomit, you can actually listen to examples of, let's call them typical coughs. And there's a link in the useful resources box at the end of the written pearl. It's also on Red Whale Knowledge, and I'll put a link in the show notes too.
Yes, do go and have a listen to those different types of cough. It's a really useful way to cement the learning. It's also important to say that pertussis may occasionally present with breathlessness, wheeze, fever, flushing, or stridor. And in infants, it may present with difficulty feeding, apneic episodes, or diarrhoea. And the significance of pertussis is that it causes infant hospitalisation and death. So tragically, in England, there were 8 reported infant deaths between January and April in 2024. And the most vulnerable are preterm infants aged under 2 months, regardless of whether their mother was vaccinated in pregnancy, term infants under 2 months of age with an unvaccinated mother, infants in the window of 2 months to 5 months of age, regardless of their maternal vaccination status. Just to explain, because that puzzled me for a minute, that's those infants who aren't covered by maternal vaccination and have not yet had their own vaccinations. And then infants 5 months up to 12 months of age who've not completed their primary vaccinations. And vaccination during pregnancy and completing infant immunisations on time, so that's the 8, 12 and 16-week vaccinations, provides the best protection to infants. Colloquially, pertussis is known as the 100-day cough, and that's because it can last 3 months or more.
Yes, and that's the label that the media seized on last year when reporting on pertussis. And in May last year, or 2024, if you're listening beyond 2025, the Express had the headline, "Urgent 100-day cough warning after baby dies of highly contagious infection in the UK." And they weren't alone, with all the tabloids having similar headlines, which explains why I can remember several of my patients asking me, do you think this is the 100-day cough? So how do we answer that question if a patient asks, when should we suspect pertussis? Well, the UK HSA guidance states that a suspected pertussis case is when a clinician suspects pertussis, which by itself is perhaps not very helpful, but thankfully it then goes on to give us a bit more detail. So they say that suspected pertussis may include those presenting with a new cough with no clear alternative cause, plus any one or more of paroxysms of coughing, post-tussive vomiting, so vomiting after coughing, inspiratory whoop, and we've discussed before, we don't think it's a hoop, so inspiratory whoop, and a cough more than 14 days. And they also say that suspected pertussis could also present to us as an epidemiologically linked case. So that would be a patient with any signs and symptoms of pertussis and in close contact with a laboratory confirmed case of pertussis in the last 21 days.
And remember that prior vaccination doesn't preclude infection. So a US cohort study suggested that the protection offered 5 years following the last dose is around 70%. That's from the New England Journal of Medicine in 2012. And pertussis is a notifiable disease in the UK, so we need to report all suspected cases to our local health protection team. And this bit is important. Don't wait for laboratory confirmation before reporting. And another reason for getting in touch with your local health protection team is that they will advise on testing. So in the first 21 days, confirmation is with Pertussis PCR. That's from a throat, pernasal or nasopharyngeal swab or nasopharyngeal aspirate, and culture. And the culture's from nasopharyngeal or pernasal swab. And from 2 weeks and onwards, testing can be via an oral fluid sample or serology, as in a blood test. And your local health protection team will post an oral fluid kit directly to the suspected case if they're being tested that way. If you want more information on the testing guidelines from the UKHSA, there is a link in the written pearl in the article on Redwell Knowledge and also in the show notes. And as you will see, if you read the testing guidelines, between 2 and 3 weeks, PCR and culture plus either an oral fluid sample or serology are offered. So if in doubt about it, speak to your local health protection team.
And thinking about treatment now, and the clinical benefit of antibiotics in pertussis is limited. Benefits are greatest in the early catarrhal phase of the illness, but this window of opportunity may be missed because it may not be suspected until later. So let's look at the treatment of cases first, and then we'll go on to consider the treatment of contacts. Now, with the treatment of cases, there are 2 important groups to consider. The first group is pregnant patients, and the second group is where the case has close contact with pregnant women or vulnerable infants, and this includes nursery or healthcare workers involved with children aged less than 3 months. If the patient is in either of those 2 groups and it's been less than 21 days since the onset of the cough, then we would give antibiotics. However, beyond 14 days, the main benefit of antibiotics is to reduce transmission. For everybody else, if it's been less than 14 days since the onset of the cough, we should consider antibiotics, though they have a limited clinical benefit. If it's been 14 days or more since the onset of the cough, we should not offer antibiotics. What about the treatment of contacts, Ali?
So antibiotic prophylaxis is offered to close contacts of a case of pertussis if the onset of the cough in the index case was less than 14 days ago and the close contact is in a high priority group. So to make it as clear as possible, Nick and I are now going to alternate talking about the different high priority groups. So a high priority group is defined as any one of unimmunised premature infants born before 32 weeks gestation, aged less than 2 months, regardless of maternal vaccination status.
Unimmunised infants born 32 weeks or more, aged under 2 months, if the mother did not receive vaccination between 16 weeks of gestation and 2 weeks prior to delivery.
Infants in the window from 2 months to 5 months of age, regardless of maternal vaccination or gestational age at delivery.
Infants aged 5 months to less than 1 year who have received fewer than 3 doses of a pertussis-containing vaccine, regardless of maternal vaccination status or gestational age at delivery.
A pregnant woman at 32 weeks gestation or beyond.
Healthcare workers who care for any of the infant groups mentioned already or pregnant women.
People who work, meaning having regular prolonged contact with infants who have been defined by us already.
And finally, people who share a household with an infant listed in the definitions that we've just given. So it's well worth having a read of the Pearl or looking at the article on Redwell Knowledge to have a proper read of the list.
Yes, and additionally, if the case is a healthcare worker, further rules apply to cover potential contacts who may have been patients. So we suggest speaking to the UKHSA or Occupational Health for advice in that scenario. Prophylaxis beyond close, prolonged household contact has limited evidence of benefit. And antibiotic doses are the same in prophylaxis as they are for treatment. The UKHSA have recommended antibiotic regimes, so it's worth having a look at the table in the written Pearl, on Redwell Knowledge, or in the UKHSA guidance. And there's a link to that guidance in the show notes. And as you'll see when you have a look, macrolides are the order of the day, namely clarithromycin, azithromycin and erythromycin, with cotrimoxazole being an alternative if macrolides are contraindicated or not tolerated. And from the table, the best option for neonates is listed as clarithromycin, and it's flagged up there that cotrimoxazole is not licensed below 6 weeks of age. For pregnant women, erythromycin is listed as the preferred option because it's not known to be harmful. azithromycin is second line and clarithromycin third line. And we're reminded that cotrimoxazole should not be used in pregnant women, especially in the first trimester, unless there's no other antibiotic option available. And I suspect we would be involving our local health protection team and friendly consultant microbiologist in any decision of that nature.
Exclusion now, and it's worth highlighting that exclusion aims to limit onward transmission of pertussis. Now, you'll be able to appreciate in a minute when we discuss it all that antibiotics reduce the exclusion period significantly, and exclusion for contacts is not required. So let's consider different population groups, and all the exclusion periods we discuss are the same whether it's a suspected or confirmed infection. Our first population group to consider is children. Now, they can return to school or nursery 48 hours after starting antibiotics. If not treated with antibiotics, they can return to school or nursery 14 days after the onset of the cough. Next, we have staff in nurseries or childcare settings or schools. Now, they can return to work 48 hours after starting antibiotics. If not treated with antibiotics, they can return to work 14 days after the onset of the cough. So you can see a pattern developing here. Right. So next up, staff working in nurseries or childcare settings providing close personal care to vulnerable infants. Now, they can return to work 48 hours after starting antibiotics. If not treated with antibiotics, they can return to work 21 days after the onset of the cough. So that's a massive difference there. And our final population group is healthcare workers providing close personal care to vulnerable infants or pregnant women. They can return to work 48 hours after starting antibiotics. If not treated with antibiotics, they can return to work 21 days after the onset of the cough. It's important to inform occupational health and the infection control team as soon as possible, even if it's more than 21 days since the onset of the cough. So, what about vaccination in pregnancy, Ali?
Well, pregnant women are offered pertussis vaccination between 16 and 32 weeks, and this is designed to boost levels of circulating immunity, which can be passed across the placenta, and offer passive immunity until primary immunisation of the baby starts at 8 weeks of age. Maternal vaccination is more than 90% effective in preventing hospitalisation and death in infants. But maternal vaccination rates across England in 2024 are less than 60%. There's less benefit if vaccination occurs after 32 weeks of pregnancy, but it should still be offered if it hasn't been done before. And women should be offered vaccination in every pregnancy. From July 2024, the preferred vaccine is Adacel. That's a vaccine against Tdap or tetanus, diphtheria and pertussis, rather than the previously used Boostrix IPV vaccine. That's because a review of evidence by the Joint Committee on Vaccination and Immunisation, or JVCI, found that infants born to mothers given Boostrix IPV had lowered antibody levels to polio after primary vaccination, although it was still above the protective threshold. So this reduced antibody response to polio has not been seen in the non-IPV containing Adacel vaccine. If Adacel is not available, Boostrix IPV should still be given because the risk of pertussis infection in infants outweighs the potential risk of those reduced antibody levels to polio. Tdap, as in tetanus, diphtheria and pertussis vaccine, has been used in maternal vaccination programmes in Europe, the USA and Australia with good safety and efficacy. And millions of doses have been administered worldwide. That's from the UKHSA in 2024. And 2 large observational studies provide reassuring evidence for the safety of the vaccine in pregnancy as well. So there was a large observational study in the UK which showed no increased risk of stillbirth, no increased risk of maternal or neonatal death, or of preeclampsia or eclampsia, no increased risk of hemorrhage, fetal distress, uterine rupture, placenta or vasoprevia, caesarean delivery, low birth weight, or neonatal renal failure. So that's all very reassuring. That's from the BMJ, published in 2014. And also a large US retrospective cohort study looked at the safety of pertussis vaccination, so the US Tdap immunisation, and it identified a very small increased risk of chorioamnionitis and an apparent lower risk of preterm delivery. That's from the Journal of the American Medical Association, also in 2014. So the authors of that study recommended caution in interpreting that apparent slight increased risk in chorioamnionitis following vaccination, and they suggested that this could be due to residual confounding and accuracy of the diagnosis of the condition. They were also unable to fully correct for bias when assessing the risk of preterm delivery. So Nick, what have you got for us on vaccination of healthcare workers and children?
Well, the Green Book tells us that vaccination is also offered to unvaccinated or partially vaccinated children up to the age of 10 years, and some healthcare workers who have not received a pertussis vaccine in the previous 5 years. And they highlight 2 priority groups here. So priority group 1 are healthcare workers in close and regular clinical contact with severely unwell infants aged under 3 months and women in the last month of pregnancy. And priority group 2, now these are healthcare workers in regular clinical contact with unimmunised infants in hospital or community settings. Now, eligibility for occupational vaccination is dependent on circulating levels of pertussis, and the UK HSA guidance has got full details on that. So here are your learning points for pertussis. Vaccinated individuals can get whooping cough. They just don't whoop. Or is that hoop? Suspect pertussis where there is a history of cough, 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 vomit.
Diagnosis can be confirmed by PCR and culture before 3 weeks or serology and oral fluid sample after 2 weeks. Offer antibiotics to cases of pertussis who are pregnant women and those in contact with pregnant women or vulnerable infants if symptom onset is within 21 days. The purpose of this is to reduce transmission.
The benefit of antibiotics on the clinical course of the disease is limited. Cases should be excluded from work for 48 hours after commencing antibiotics or 14 to 21 days if untreated.
Pregnant women should be offered the vaccine Adacel Tdap between 16 and 32 weeks of their pregnancy to reduce the risk of transmission to their infant and provide passive immunity. Vaccination should be offered again in every pregnancy.
And breathe. And that's the first pearl of the month done. So how are you doing, Ali? And what have you been up to since you were last here?
Yeah, I'm very good. Thanks, Nick. It's been Christmas since I was last here. So yeah, we had a lovely Christmas. One of the highlights was my youngest excelled in her pivotal role of sheep in the school nativity. That was really nice. She was very cute. My eldest had a Christmas recorder concert, which was also lovely, although I feel like it's still permanently damaged my ears.
Do you know, that brings me back to school. I remember being in recorder classes and the guy sat next to me, who's still a friend now, would literally just blow as hard as he could and just wiggle his fingers. And it just made me laugh. I would always get the giggles because he clearly had no clue. I mean, I was trying my best, but he would just go, just blow the recorder and it was just brilliant. And yeah, if ever having a bad day, think about that because it always puts a smile on my face. So there we are. So shall we move on to our second pearl of the month?
Yes.
Okay, so this one is prophylaxis for sexually transmitted infections. Now, this one took me 7 minutes and 40 seconds to read, so a nice quick one. What did this one mean for you, Ali?
Well, this article reminded me a bit about our conversation about monkeypox a few episodes ago, actually, and this idea that we can have a lot of inbuilt prejudices around STIs and the groups of people who are at increased risk of them. You know, and we can make assumptions about those groups. And in reality, we've all got patients registered with us, I'm sure, who this stuff is very, very relevant to. So it's kind of pushing against that idea that maybe this isn't for me or my population group. And it's just so important that we give good quality information in a sensitive way to people who need it and make sure that people can access the care they need.
Yeah, and it's absolutely right. And it's about not making assumptions about what people sort of do as well. And it's about being able to have those open conversations, because it might be that the person in front of you hasn't had the courage to talk about what they're going to talk about regarding their sexual health with anybody else. And it might be the start of a process. And, you know, a lot of people, particularly if they are having a difficult time or they haven't maybe come out yet, if they're gay, then it can be very stressful to kind of have almost like a double life. So we need to almost have a poker face where we are unshockable and we can talk about anything like this, even if it's something like this, which is an evolving area. And it might be that the guidance that we've got at the moment isn't quite matching what maybe people are doing, and that may well change. And that's an interesting thing that we can watch as we go forward. So there is established evidence and guidance supporting the use of pre and post exposure prophylaxis for HIV. And we all know about that. And you can read more about that on Red Whale Knowledge if you want to brush up on that. But there's also growing evidence for the use of antibiotics to prevent STIs that are not HIV. However, in 2021, the British Association for Sexual Health and HIV, so that's BASH, and the UKHSA, the UK Health Security Agency, published a joint position statement against using antibiotics in this manner for STIs. Now, despite this joint position statement, evidence from cross-sectional surveys suggests that the use of antibiotics as prophylaxis against syphilis, chlamydia and other STIs is increasing. And the 2019 HIV PrEP survey found that 9% of respondents reported using prophylaxis. And this was associated with what would medically be termed as high-risk behaviours, such as having had 5 or more condomless sex partners in the past 6 months, having had chemsex in the past 12 months, or having had an STI in the past 12 months. Now, this is on a background of limited evidence of benefit and risks of antimicrobial resistance. So what's our role in primary care if a patient approaches us for advice on this issue? Well, the Written Pearl, an associated article on Red Whale Knowledge, was updated in June 2024. And if this is an important area for your CPD, then did you know that there are 51 articles on Red Whale Knowledge covering all aspects of sexual health and contraception? So Ali, can you tell us a bit more about the BASH and UKHSA guidance?
Yeah, so as you said, Nick, in 2021, BASH and UKHSA published this joint position statement against the use of antibiotics as pre or post-exposure prophylaxis against STIs. Doxycycline, taken as pre or post-exposure prophylaxis for syphilis or chlamydia, is not endorsed by BASH or the UKHSA. The use of other antibiotics for prophylaxis for syphilis and chlamydia or to prevent other STIs is unlikely to be effective, and what they say is it should be discouraged. So if patients are taking doxycycline prophylaxis, they say clinicians should advise on the risks of antimicrobial resistance and the limited evidence of benefits. And they say we should also offer monitoring for adverse effects.
So what's the evidence base for this?
Well, at the time of the statement back in 2021, the evidence base was a single study in men who have sex with men, and this was called the IPERGAY or IPERGAY trial, published in the Lancet Journal of Infectious Diseases in 2018. It was a French trial, and 232 men who have sex with men were recruited, and these men were all already using pre-exposure prophylaxis or PrEP for HIV. So just a reminder, that's HIV negative people using pre-exposure prophylaxis. The men were randomised on a 1-to-1 basis to a single post-coital 200mg dose of doxycycline prophylaxis or to no prophylaxis within 24 hours of any episode of unprotected anal, vaginal or oral sex, with a maximum of 3 doses per week. The primary endpoint of the trial was any STI, and overall there was a 47% reduction in the relative risk of a new STI. There was no benefit, though, shown in rates of gonorrhea, and it was felt that was possibly due to the known high rates of doxycycline resistance in France. So resistance rates are 56% in France versus 20% in the USA.
Okay, so has the picture moved on since then?
Well, in October 2023, the Centers for Disease Control and Prevention, or CDC, in the USA released draft guidance on the use of post-exposure doxycycline to prevent sexually transmitted infections, and that has since become formal guidance. Their guidance is for gay, bisexual and other men who have sex with men and trans women with a history of at least one bacterial STI, so gonorrhea, chlamydia or syphilis, in the past 12 months. No recommendations are given in that guidance for cis women, cis straight men, trans men or other queer or non-binary people due to lack of evidence in those groups. And their prophylaxis regime is that doxycycline 200 milligrams should be given as a single dose by mouth within 72 hours of oral, vaginal or anal sex for those groups described, with a maximum of one dose in any 24-hour period.
It also suggested that clinicians prescribing doxycycline prophylaxis should consider the following: advise of potential side effects, including skin sensitivity, GI discomfort and esophagitis and the risk of antibiotic resistance. Advise of potential drug interactions, so separate dosing by at least 2 hours from antacids and other calcium, iron or magnesium containing medicines or supplements. Advise that contraception should be used by people with reproductive potential, and provide enough doses of doxycycline to last until the next follow-up visit based on a discussion with individual patients. They also advise about screening for HIV, gonorrhea, chlamydia and syphilis every 3 to 6 months. So what about the evidence base for this guidance, Ali?
Well, this newer CDC guidance was based on evidence from 2 2023 New England Journal of Medicine studies and from the IPEGA trial I mentioned earlier. So thinking of these two NEJM studies, there was the DoxyPEP trial, which was a US trial that recruited 500 men who have sex with men and trans women as well, all people taking PrEP for HIV and with a confirmed STI within the past 12 months. And this group were randomised on a 2-to-1 basis to take 200 milligrams of doxycycline within 72 hours of any episode of unprotected oral, anal or vaginal sex, or they were randomised to no treatment. And the primary endpoint was incidence of STI, and this population were followed up for 12 months. So what this study found is that there was a number needed to treat of 5 to prevent one STI over 3 months. And there was an overall reduction in STIs by 2/3, as well as no serious adverse events being found. Overall rates of doxycycline-resistant Staph aureus were slightly higher in the prophylaxis group at the end of the trial, but the effect was pretty minimal, with 5% in the treatment group compared to 4% in the no treatment group. But what's interesting, though, is a replication of the IPEGA trial methods on a population of cis women in Kenya did not show the same benefit. So there were low rates of doxycycline use, with 44% of women not taking any doses, and all the gonorrhea found on testing was tetracycline resistant. So there's definitely a need for further research into preventative options for STIs that are acceptable to women.
So that's what's happening in the USA, and this is clearly an evolving area. So watch this space, because the guidance might change over here in light of this. But for now, what should we be doing in primary care according to the guidance in the UK? Well, BASH advises that we should ask patients about recent use of antibiotics as prophylaxis to prevent STIs, and document which antibiotic or antibiotics that they are using and how. So obviously writing the regime down. So we should give patients the information that the use of antibiotics as STI prophylaxis is not recommended in the UK because of concerns of antimicrobial resistance. Use of antibiotics in this way is off-label. Studies have only looked at doxycycline for prophylaxis against STIs. No other antibiotics have been tested. And the current evidence is only in chlamydia and syphilis, not gonorrhea, mycoplasma, or viral STIs. And we should also advise patients, where relevant, that doxycycline is not safe in pregnancy and offer contraception if appropriate. And you might be thinking that it's unlikely that this issue will find you in your surgery. Well, just by doing a bit of reading around this and discussing this in preparation for the podcast, my Instagram feed has suddenly shown me an advert that hasn't been in my timeline before, and it's from an online pharmacy, and the advert says in big letters, "Prevention backed by professionals." You've guessed it, it's an advert for DoxyPep. And it says, stay protected with DoxyPep, ! Rainbow emoji, full stop, fast, discreet, and now at a reduced price, pill emoji. Order today for peace of mind, shield emoji. So that was in my timeline. So people can access it in the UK, even though it's against the BASH guidelines. So it might be something that comes into your consulting room. So here are your learning points for prophylaxis for sexually transmitted infections. There is evidence of increasing use of antibiotic prophylaxis against STIs. The evidence base is limited to small studies of men who have sex with men and trans women. In the UK, BASH and the UK HSA guidance from 2021 advises against the use of antibiotics as pre or post-exposure prophylaxis against STIs.
In the US, the CDC has new guidance on post-exposure prophylaxis with doxycycline for men who have sex with men and trans women at increased risk of STIs. We should be alert to the fact that patients might be using antibiotics sourced elsewhere for this indication, such as online pharmacies, and we should provide relevant information on safety if indicated.
Ali, you got the Redwell calendar there.
I have indeed. So we've got loads coming up. We're just coming into our team conference at Redwell. So we're going to get together in Wales and we have a day, we call it our boot camp, where we all practice our presenting skills, and then we get together and talk about what we're going to be teaching in the next season. So that's all really exciting. We've got loads of courses coming up. We've got the urgent care courses, the mental health course and the menopause course. They're all super useful. And there's a GP update season still going on at the moment that you can join live courses for. I'm presenting the next one later this month. And also our new trainee package has been really popular, hasn't it, Nick?
Yes, it has. So the GP Trainee Essential Support Package, this is exclusively available to GPST MDU members and affiliates. So if you're one of those, then it's free and it's worth £165 and it's designed to build your knowledge and confidence and help you pass your exams. So what is included in that, I hear you ask? Well, it's really helpful because it's got Redwell Knowledge Access, which is over 900 written resources to support you during consultations and also with your CPD. And also the Top AKT Topics Digital Handbook, which covers areas that trainees struggle with most, and webinars throughout the training year to support you with your exam preparation. So if you click on the link, then you can sign up for that.
And just to give you the terms and conditions for that package, so the package is completely free for MDU affiliate and GPST members, but MDU GPST membership itself does carry a charge to sign up. Our GP Trainee Essentials package is a free benefit of affiliate and GPST MDU membership.
And we just got time for our primary care superheroes, so here we go.
So this one comes from one of our recent face-to-face courses. The person nominated is Dr. Sam Holden, a GP at Castlefield Surgery in Stafford. The person nominating them said they are motivating, enthusiastic, they keep everyone's morale high, and they get tea and coffee. That's very important, isn't it? And it also says that they're happy to answer questions from anyone. So yeah, sounds like a great GP.
Brilliant. So thank you for that one. And I've got Louise Austin here from Sapperton Medical Clinic in Canada.
Wow.
Now, she's an office manager. Yeah, wow. Hi to you in Canada. She has the answer for everything for experienced staff and new staff alike. She is high energy. She can make you laugh no matter what the situation or how bad you're feeling. And she can always see the funny side. So thank you and hello to you, Louise. And finally, 5690 on the texts. They've contacted us and they've sent it along by clicking on the message in the show notes. They've said, really appreciate the progestin dosing podcast, something that I've been wondering about for a while. So thank you for that. Now, if you're hankering after a Redwell Knowledge subscription, then we're offering a 10% discount on Redwell Knowledge for our fabulous Redwell pod members. So how do you become a member, I hear you ask? Well, if you're listening to us, then you are part of our pod. So hello. And all you have to do is you go to redwhale.co.uk, put Redwell Knowledge in your basket and enter the code Red Whale Pod to get 10% off. And here's the small print. The discount is only for this product and it won't work on anything else, as hard as you might try. But please also note that this voucher code is all one word and it's all lowercase. So Red Whale Pod.
And if you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds of your time and we'd really appreciate it. If you can spare it a little more time, then please leave us a nice review. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want to see something about the podcast, then please use #RedWhalePod.
Yes, and I've just gone and experienced Blue Sky. So I've joined Blue Sky myself, so I wonder if we'll end up there someday. So the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.